Okay, so as you know, today the total number of cases so far are 331,000, with a total of 14,450 deaths in the United States. We have 33,000 cases and total of 416 deaths. And here the graph for all the cases since the start of the pandemic, or actually a little bit after the start of the pandemic on January 20th. But you can see the cases, the decrease here is because of China started to go down, and then the rest of the world started to go up, and we're on the acceleration phase. This is today, and the green would be the recovered ones, and the red would be the new confirmed cases. And today is not finished yet, so we'll see if this is going to be higher than yesterday, and we'll follow this on a day-by-day basis. The source of this information, again, is the Johns Hopkins University, and they have a very good site where you can actually track everything on a daily basis, hour by hour. What we will be talking about today, the characteristics, the outcome, testing performance characteristics, and radiology findings. And the initial study, I think this is one of the initial studies that was published in New England Journal of Medicine, talking about clinical characteristics of coronavirus disease in China. And based on this study, we were able to put a diagram on the course of the disease. We knew that the incubation time is around 5.2 days, which is the median, but the range is between 1 to 14 days. Then the patient might present with any of these symptoms: fever, cough, myalgia, shortness of breath, and we had CT scan findings in 86% of the cases. Diagnosis was confirmed with the PCR that was positive on nasopharyngeal and or oropharyngeal swabs. Lower respiratory tract specimen were better, sputum and bronchoalveolar lavage. According to this study, 14% of the cases were severe, 5% were critical cases, and the majority of the cases were just mild cases. So about 20% of the cases are either severe or critical, and the rest will be either mild or moderate. And based on this study, also they identified that patients with more advanced age and chronic comorbidities had a higher mortality. The mortality rate overall was 1.4%, which was initially thought that the mortality rate is going to be lower than what we had in the MERS and SARS covirus 1. And this is also the epidemiologic graph or curve for the China outbreak, and the dark black color rectangles are the severe cases, and you can see on average the severe cases are between 15 to 20% of all cases. Those are the darker ones, are the ones who were admitted to the intensive care unit. So this is the experience from China. Now we have much more drastic experience from Italy, where as on the date of publication of this article, which is the 17th of March, they had 22,500 cases. And take a look on the number here of people who were healthcare workers, total of 2,026 almost 10% of the cases were among healthcare workers, indicating the real importance of following strictly the infection control measures and making sure that we identify those cases the minute they come to our ER, so we don't get exposed to any of those cases. You probably know that unfortunately we had a case that was not diagnosed on arrival, and some of our residents and healthcare workers in the hospital have been exposed, and you probably know more details about this case. We need to make sure that we don't get into a situation that a good percentage of us are exposed, and then we have to be quarantined. Of course, some of us will get the disease too. So the alarming thing in the Italian experience is the death rate. And on the day of publication, they had 1,625 deaths, which is close to 7% mortality rate. And you can, if you're following the news, the mortality rate has increased since then. According to their experience, the median age was around 64 years. So relatively, I thought it would be higher a little bit, but the age population, the population age is not as I expected. Almost 38% above 70 years, good percentage actually, and that's why probably why they had a high mortality rate. I don't know the percentage of the Chinese study though. Between 51 and 70 years, 37%, and only 25% for 50 years or less. More predominantly males, and you can see here, based on the severity, total of 30% of the cases were severe. 46% mild, and some of those no symptoms and specified symptoms, but the point here is 30% of the population of the patients who had the disease had it in severe condition. And this is the mortality rate. You can see a total of 1,625 with a mortality rate of 7.2%. Clearly, as you go up with the age, the mortality rate would go up. Between 50 to 59 is 1%. Very similar to the Chinese data, 1.6%. Between 60 and 69, 3.5. And take a look over 80 years in the Chinese data, it was 14.5. Here it is almost 20%. Above 90 years old, they had 156 deaths, which is 10% of total. So this is the probably indicating that they had a good number of higher age group in the study. And that had a mortality rate of almost 25%. Now we come to the States. The first study that was published is on March 19, 2020 in the JAMA, and they're talking about characteristics and outcome of only 21 critically ill patients with COVID-19, and this is in Washington State. Unfortunately, the study included mainly those patients who came from nursing home. So majority of those patients came from nursing home. So they were actually having comorbidities in a good percentage of those cases, total of 18 cases, 86% of them had comorbidities, one or more comorbidities. The presenting symptoms were shortness of breath in 76%. It was the predominant presentation symptom. And then followed by fever in 52% and cough in 48%. The mean age you see here 70 years. They were older population, and here half and half were males and females. Again, it's a small number of cases. This is the first reported cases in the literature in the States, and They had identified the comorbidities. As I said, a total of 18 comorbidities, but you can see it included everything that we know about: COPD, congestive heart failure, chronic lung disease, diabetes, obstructive sleep apnea. Chronic kidney disease was seen in good percentage. Actually, 50% of patients had chronic kidney disease, followed by the congestive heart failure and diabetes after that. End-stage kidney disease, history of solid organ transplant, and cirrhosis with immunosuppression formed the remaining number of comorbidities. So this is based on 55,000 or almost 56,000 laboratory confirmed cases as of February 20th, 2020. So most of the data is from China. The majority of symptoms were first fever, followed by dry cough, and then fatigue in 38% of the cases. Shortness of breath was only present in 19% almost, myalgia, arthralgia, and it could be sore throat in 14%, headaches 14%, and then you have chills, nausea, vomiting, nasal congestion, very low percentage, diarrhea, hemoptysis, and conjunctival congestion. So in fact, all those symptoms of the flu-like plus lower respiratory tract infection would indicate that this might be secondary to COVID-19. It was indicated in the Lancet in this graph that the majority of the cases were like mild onset of symptoms here, and symptoms are mild to moderate. However, on day 6 to 7, they get worse, and patients may be admitted to the hospital. And shortly after that, they may develop ARDS, and could be severe ARDS. They ultimately get admitted to the intensive care unit. I have a better description of the course in the following slides, but I thought this is nice to show the illness course. So the clinical course and risk characteristics was well identified in a study that was published on March 11th. I think this is the Lancet. And in this study here, I'm going to stop a little bit here so you can understand this graph. I think this is the most important graph in the whole lecture. We're looking at medians, and they divided their patients at, they think 200, let me see if I have a number here, 191 patients altogether. And those are severe cases of COVID-19. So they divided them into survivors and non-survivors, and they looked at the characteristics of these two groups. So in the survivors, you can see that the median length of the fever was around 12 days. The cough persisted for longer time, a median of 19 days. And dyspnea started typically after 6 to 7 days and lasted for about 10 to 12 days. And ICU admission followed that. However, those patients did very well. For some reason, most of those patients received systemic corticosteroids, and they have the median time for the corticosteroids. And the positivity of the PCR was at all times. You can see from day number 1 all the way, and they recovered here, those patients. However, the PCR continued to be positive on a median of 1 more day on top of the symptoms. This is compared to patients with severe disease. Same thing, the fever and cough, almost the same thing. And then those patients developed shortness of breath on day number 6, and then ICU admission on day number 11 or 12, and then followed by invasive ventilation. So 2 or 3 days in the ICU, and then patients got intubated here. They were intubated for 1, 2, 3, 4.5. This is the median of 4.5 days. Majority of the patients were just intubated for 4 to 5 days. And also they received corticosteroids, and their PCR was positive all the way till the death. So those patients were infected throughout. On day number 8, majority of cases developed sepsis, and day number 12 cases here developed ARDS. In the survivors a little bit earlier. But those patients also in day number 15, they developed acute cardiac injury. Acute kidney injury was developed on day 15 also, and some of those developed secondary infection, and then the death occurred almost 3 weeks after the start of the symptoms. So for a very drastic course, however, this explains why most of those patients probably were outpatient coming to us. The 2 patients who arrived to us died within 24 hours. They probably were outpatient. And we know the type of patients we get at West Sub, and we lost those patients very rapidly after they come to ICU. So the other important thing that we need to address is, so do we have any risk factors that would tell us that this patient would develop acute respiratory distress syndrome or not? So as you see here, it takes time before they develop this syndrome. So the question is there a way we can determine who will develop severe cases, so we can actually keep an eye on them, put them in a higher level of monitoring? And based on this study, it's actually not very well, it doesn't answer all the question very well, because they only found advanced age is the most important factor, which is well known. Also, they looked at lymphocytopenia, neutrophilia, elevated LDH, and elevated D dimers. So they were all associated with increased risk for development of ARDS. They found, ironically, they found that fever was a good indicator, that those patients who developed fever did not actually progress into ARDS. But this is collected from different sources, and they came up with a criteria for progression or high risk of progression towards severe disease. And this criteria is the presence of one epidemiological factor plus one of the vital signs or laboratory values. So it could be any of this, the age more than 55, or pre-existing pulmonary disease, chronic kidney disease, diabetes, cardiovascular, hypertension, transplant, immunosuppression, all other patients with HIV, regardless of all patients with HIV, regardless of CD4 count. Also, use of any directed biological therapy would be a risk factor for progression into severe disease. If you have a patient with respiratory, if you have a patient with one of this plus one of the vital signs, such as respiratory rate more than 24 breaths per minute, heart rate more than 125, or saturation less than 90% on room air, at that time, this patient has a high risk of progression. It also could be one of the laboratory findings. That's why we will recommend to do this almost every other day. D dimers more than 1,000, CK twice upper limit of normal, CRP more than 100, LDH more than 245, elevated troponin, and lymphocyte count less than 0.8. This is the absolute, and then ferritin more than 300. So what is the outcome data that we know? We already mentioned some of this, but I want to summarize everything together in this table. So I listed all the studies that we have, and you can see the first column here is the number of cases. So we have the Chinese, the biggest study is the Chinese study, which has 1,099 patients, 138 patients here. This is the study that we just presented, 191 patients, and you have the other studies. This is the American study with the 21 patients. Then the second column here, you can see the ICU admissions. So if it is 100%, that means this study is for severe cases admitted to the intensive care unit. Similarly, the American study was just the ICU patients. However, the rest of the studies included patients with severe plus mild and moderate cases. So like the Chinese study, 5% of the patients were severe, and 14% were I'm sorry, 5% is critical, 14% severe, and the remaining were mild to moderate. So we're looking at the cardiac injury. It was reported to be somewhat between 7% to almost as high as 33%. This is the American study, and those patients were older patients, sicker and died higher in higher percentage. Cardiac injury was seen up to 33%. Similarly, the shock was the highest in the American study. In this Chinese study with the 52 patients, all ICU patients, you see it in 35% of cases. So the shock is seen in the intensive care unit between 35 and 70% of the patients. The percentage of shock in the other ones between 1 to 20%. But as I said, this will be these studies had mixture of patients between severe and critical patients. Use of non-invasive mechanical ventilation. This has been actually looked at carefully, and we do not advise to start patients on non-invasive ventilation unless the infiltrates on the chest X-ray are minimal and patient is not severely ill. So if you want to start the non-invasive, it is advised to be shortened for very short duration and see how the patient is doing. And if you do non-invasive, you need to put the patient in a negative pressure room and have all protective measures worn by all the house staff in the hospital and the healthcare workers. The non-invasive mechanical ventilation is aerosol generating procedure, so you need to really protect yourself in those patients. Now take a look on the invasive mechanical ventilation column here. You will see that 71% in the American study required mechanical ventilation. In the Chinese study in the ICU here, 42%. So on average, 40 to 70% of patients would require to be intubated and placed on mechanical ventilation. And the rate of invasive mechanical ventilation in patients who are not, if we put all patients together, is between 2.3 to maximum of 12 or 17%. Case fatality ratio. The Italian study, 7.2. I don't know why I did not put it here. 7.2%, and the Chinese study, the initial one is 1.4%. You can see the American one is 67%, but it has a high percentage of nursing home patients with average age of 70%. So this does not represent what's the mortality rate that is going to be in our patients in the ICU. The other study in the ICU here, mortality rate was 62%. So I would suspect it's going to be around 50 to 60% mortality rate in the ICU altogether. Mortality rate based on the age, we presented the Italian data, but this is the data based on the Chinese patients, total of 55 or 56,000 patients. You can see the mortality rate goes up as the age increases. At age 50 and 59, 1.3%, 3.6% for 60 to 69, 8% for 70 to 79, and 15% for 80 or higher. Also, mortality rate is dependent on comorbidities. If you have any of this, the mortality would be higher. The highest was for cardiovascular diseases, and diabetes was 7.3%. Cardiac diseases such as congestive heart failure would be around 10.5%. Chronic respiratory diseases, COPD, chronic asthma, 6.3%. Hypertension, 6%. And it is not clear why hypertensive patients, even if the blood pressure is controlled, those patients were at a higher risk of mortality. And cancerous patients, 5.6%. And if there is no healthcare condition, no other health condition, at that time the mortality rate would be around 0.9%. So even the younger population has a mortality rate that is considered relatively high. You can see here it is between 0.2 to 0.4%. And if you add one of the comorbidities, the mortality rate will actually go much higher, even in younger population. So do we have any information about testing? Of course, we're looking for the sensitivity and the specificity of the test, so we can attribute those results based on pre-test probability. And we know that the test that initially was released was made by Hologic molecular test company, and the test characteristics in terms of sensitivity, specificity is still not yet known. We don't have the data of the tests that's been done in the States. We do have some studies looked at a correlation between the testing and CT scan, because in China they were suspecting those on clinical, based on clinical presentation, and they were almost doing CT scans on all patients who presented to them. And they looked at the PCR. So the PCR was negative in good percentage of patients on admission. And then when they repeated the test later on during the course, the negative PCRs turned out positive, and this is how they confirmed the cases. So they consider any case that turned out to be positive was positive at the beginning, but was false negative. And that's why they say that CT scan is probably more sensitive in determining the COVID-19 patients with pneumonias. So we're not doing CT scans on all the patients. We also have not seen our own testing characteristics. It could be higher sensitivity and specificity, so we'll see, but we did not think that those patients should be actually running around in the hospital to the radiology department and getting the CT scans of the chest done for them. So at our hospital, we're not doing CT scan for those patients, and there's no reason why we should do CT scan. If you're suspecting a severe case, you can put the patient in the hospital and monitor this patient and treat the patient empirically if needed. The average time, is it the median here? The mean, yes. The mean time between the initial negative to positive PCR was around 5 days for those patients in the Chinese study. So do we have any specific radiological findings consistent with COVID-19? In fact, you can see any type of infiltrates that you ever seen with all kinds of diseases. You can see patchy infiltrates bilaterally, like this one here, and you can see fluffy infiltrates bilaterally, typical for what we see with ARDS, and you can see also more of consolidative process, or you can think that this is pulmonary edema. You get confused between pulmonary edema and those patients also, especially with certain conditions. More consolidation in the right upper lobe, interstitial infiltrates bilaterally, even the lower lobe and middle lobe, you can see it here. On the CT scan, you can see the multiple patchy peripheral bilateral areas. Ground glass opacity is what's typically described for those infiltrates bilaterally. This is on a patient who died after 11 days, typical for this. This is a focal area, small areas of mixed ground glass opacity and some consolidation also bilaterally in the lungs. This is a 47-year-old patient, also died. And this is a patient who went on ECMO. You can see the round glass opacity, ground glass opacity bilaterally in the lungs. After doing ECMO, you can see how the lung is relaxed, and there is a resolution of the infiltrates bilaterally. I think this patient has survived. So with this, I would like to conclude that still the most important strategy is to flatten the curve and lower the number of cases that we're going to see in the hospital. It looks like nobody is going to be escaped from seeing patients in the hospital. We started seeing patients, but what we want to do is not to overwhelm our healthcare system and ourselves with so many cases at the same time, so we won't be able to care for those patients safely, and we expose healthcare workers to those patients unnecessarily. I would like to stop here and see if there's any question. Would be more than happy to answer it. So I'm going to unmute everyone. So if you want to talk, just unmute yourself. I'm going to allow you to talk, and then just unmute yourself.
Hi, this is Hader again. Thank you for this another informative lecture. I had a question. I was reading about benefits. Some people recommending additional recruitment maneuvers to increase dead space ventilation and prone ventilation. What is kind of your view on adding those to some of our patients, and which ones were recommended or not recommended?
Well, based on the data from our knowledge on ARDS in general population, including all type of diseases, the recruitment maneuvers have shown benefits in severe ARDS. With BF ratio of less than 100, and there's a big studies confirming this, and we've been doing it in severe cases. And most of the COVID-19 cases are coming with severe ARDS, in fact, very severe diseases. So that's why if you saw the recommendation, the guidelines from the Surviving Sepsis campaign that were published recently, they recommended that they would do recruitment maneuver. If we do it, it would be not the stepwise increase in the PEEP, but the 40-40 rule, 40 seconds for 40 centimeters of water for 40 seconds. You recruit the lung, and then you put the patient back on the ventilator with higher PEEP. So it is recommended, but the evidence for this is not the highest level of evidence.
Okay, thank you.
You're welcome. I'm trying to allow everyone. Give me 1 second, please, because some of because there are a total of 40 people. I need to make sure that I give a chance to everyone to talk. Any other questions?
Hey, it's Scott Levin, Mason. Thank you so much for the talk. Have you seen any literature about whether COVID-19 positive patients or patients under investigation should be cohorted together in the hospital versus not? I guess just logically, you put all of the infection together. Does that increase the risk for healthcare workers, or is it better to have them in different places? I'm just curious if you've read anything about that from China or Italy.
Well, it is well-known intervention that we do in the hospital. to cohort those patients all together. You know, it is, I'm not sure if they studied that based on the risk to contract the virus by, I'm talking about other outbreaks and pandemics. I'm sure I did not come across anything in terms of cohorting those patients officially in studies, but we've seen the videos, we've seen the pictures from China and Italy, and those patients were cohorted. In fact, at Sanford, we decided to cohort those patients from the beginning. So we opened a whole new floor that was our old ICU. We had 8 negative pressure rooms in this ICU. And the rest of the rooms are positive pressure rooms. So we're going to start with the negative pressure rooms, and the staff will be rotating every week in terms of the physicians, and nursing staff is not different than any other. So we think this is a better way to put those patients together, and staff would be familiar with all the interventions that we do in terms of putting on and removing the protective equipments. They get used to this more. That's what we thought. So putting those patients together, we thought it would be a good idea. Again, I did not see any specific literature in COVID-19 in terms of risk of transmission, whether it's decreased or increased in cohorting those patients together.
Thank you, as always.
You're welcome.
Dr. Kerala?
Yes.
Yes, this is me, Lloyd. I have a
Lloyd.
quick question about patients who have recovered from COVID-19. I was wondering, like, how many of them are like actively having their plasma donated for reuse in patients who are having an active infection, and like how well are they doing with the plasma?
Well, this concept is an old concept. The horse muscle concept is based on this. Antibodies recovered from patients who had the disease, or plasma that's recovered from those patients will contain antibodies, and they should be effective. There's anecdotal reports about using some of this in China. I have not seen any official studies, and from the Surviving Sepsis campaign guidelines for COVID-19, they voted against using convalescent muscles or serum for those patients.
Okay. All right, thank you, Dr. Kerala.
You're welcome.
Hi, Dr. Khera. Let's Babak Solution.
Go ahead, Babak.
Hi, thanks so much for everything you've been doing. I wanted to know what your thoughts were for treating some of these patients with empiric antibiotics for, say, community-acquired pneumonia, in addition to the supportive treatment for the COVID-19.
Well, it all depends on your suspicion for bacterial pneumonia at the beginning. Because when the patient comes to you, he will come with bilateral infiltrates. Before confirming the COVID-19, you would start these patients on ceftriaxone and azithromycin. And then now we learned that it may take 2 to 4 days before you get the test back. So you probably have to keep that patient on those antibiotics, like what we do with the influenza. We start the patient on oseltamivir and ceftriaxone, azithromycin, till we get the test back. If the test comes back positive for COVID-19, and that time there's no reason for you to think that the patient should be continued on those antibacterials, unless there's suspicion for superimposed bacterial infection on top of this. At that time, it is your decision to continue or stop. If you took a look on the study that they looked at the hydroxychloroquine, you would see that 6 patients out of 20 patients were on azithromycin till day number 6 of the year. So not everyone was on antibiotics, even in that study, and the study is a French study. So the decision for antibiotics won't be any different than any other community-acquired pneumonia that you're suspecting viral versus bacteria. Once you confirm, at that time you stop the antibiotics. You're welcome.
Okay, thanks so much.
I guess next time we will be talking about treatment options for those patients. Again, I want to thank everyone who participated in working on the information sheet for the house staff, for our residents. It will be distributed to all of you. This is again not a protocol. It is not something that we want to go through official channels yet. It's only an information sheet as a quick way to make sure that this is what we want to do for our patients, to make sure that we follow the most updated and known-based practices in this. And the information that we put together is coming from the best sources, the highest level of evidence. We did not put anything that it is questionable except for the hydroxychloroquine. You will see it on the sheet. I will talk about it in the next lecture, hopefully. And this, I want to make sure that I allow everyone to talk. If you want to talk, please, you can just, and if your mic is not on, just raise your hand and I will go to you and allow you to talk. I'm not sure if anybody asked a question and send it to me by text. Let me see.
Dr. Corella, this is Joelle.
No. Joelle, go ahead.
I just had a question on the Lancet's, those two graphs from the Lancet article. Was it that none of the people in the surviving group were actually on ventilators, or did they just not include that in this data?
They did not include it in it, most likely. So I'm not sure why they did not include that. I thought it would, but this is a good observation. You're right. Where is it? Here. So no, those patients who survived, some of those patients were on the ventilator too.
Okay, thank you.